So we're getting to heart rhythms and different types of heart rhythms. And first one is sinus rhythm. And sinus rhythm means that the pacemaker is in the SA note. Okay? So it's the drummer is at the right place. Okay, so it's a sinus arrhythmia, and it could be even a tachycardia. When you're running, you can call it arrhythmia. Only if the beat is over 100. Remember, if it's you can call it sinus tachycardia, and if it's below 60, you call it sinus bradycardia. And of course, it's everything about the SA node. So its SA node is under influence of the autonomic nervous system, and of course some hormones like thyroid hormones. If you're going to have thyroid toxicosis, you're going to have a tachycardia. If you're going to have decreased levels of thyroxine, you're going to have bradycardia. Okay, so this is very typical. And of course, you can be under drugs. You can be under beta blockers, whatever. So this really like changes the sinus rhythm, but it's still the sinus rhythm. Okay, yeah. And what are the signs of the sinus rhythm? Remember, very important. You're going to see a normal P wave. There's going to be P wave. It's going to have normal shape, and it's going to be always before a normal QRS complex. QRS complex should be always have a thin normal shape. And the frequency, if it's not like stimulated or whatever, if you're not doing anything, the frequency should be somewhere between 60 and 90 per minute. Okay. Remember the top athletes, they can have really like 60 or even 50 sinus rhythm. If you're having a sinus rhythm and 50 and you are really top shape, 30 years old athlete, okay, it's normal. If you're 90 years old and you're having a 50 beat, you're having an AV block 3rd degree or something like that. Okay? Yeah. So, but remember, P has to be their QRS, and let's say it's not stimulated, so beats like if you're not doing anything, somewhere between 60 and 90. Anyways, if I will draw the heart again over here, the thing you should understand is, now, if you look on P and QRS, you should really look like when you see a P on ECG, that's a contraction of atriums. That's it. And QRS is contraction of ventricles. And that's it. And you really should imagine it in your head. And basically, yeah, when I see P, I see contracting atriums. When I see QRS, I see contracting ventricles. And basically, you can see part of that and part of that, and you can divide it, you can split it in your head, and that's what you should do for today. P, QRS. And if they're at the same time, what will you see? You will see only QRS, because the P is hidden behind the QRS. But what will you see in your brain if you would imagine what the atriums are and ventricles are doing? If it's at the same time, you will see only QRS. But you will see you will see a simultaneous contraction of atriums and ventricles at the same time, which is not good for the hemodynamics, but you can live with that. It's that the contraction of atrium is not crucial for your life. It's important for let's say when you're doing sports or whatever in exercise, and also when you're getting old, because it helps to fill the ventricles, which are not as elastic, whatever. But unfortunately, typically when you're old, the function of atrium typically really diminishes. Yeah, but it would be helpful if you would have it. Anyways, remember, normally if you're not doing anything, the ventricles are filled fully or almost fully before any contraction of atriums. Okay, so that's why you don't need them. So problems with atriums are not so dangerous, not dangerous at all compared to problems with ventricles. Okay, yeah. So sinus rhythm, clear. P is going to be there, QRS is going to be normal. And the thing that QRS is normal means that the depolarization just went the right way. It used the right tracks to depolarize the heart. There's nothing wrong with the conduction within the ventricles. When the QRS is lean, nice, normal, that means it's okay. When the QRS will look like this, it means that the depolarization could have been over here, and it took a different track. Okay, and this is we call this a bizarre QRS complex, and we'll talk about it later. If it's a nice normal QRS, it means that once the depolarization hit the AV node, it went through the normal way, and there's nothing wrong with the conduction system in the ventricles. This is what you should remember. Okay, and I'm going to repeat it many times today. Anyway, so sinus rhythm, and then you have a junctional rhythm. And what is well, I told you what is junction. It's over here. So it means that the pacemaker is somewhere in the junction. So basically, let's say SA node is dead, and AV nodes took over, and you call these junctional rhythms. So I can put here one, and over here junctional rhythm. And you have different types. You have like upper. That means that, for example, the P, it could be somewhere over here. And when the depolarization goes the other way, so typically in the second lead, it's going to be negative, the P. And then you have a QRS, that's a normal, because from over here it goes normal way. And that's upper junctional rhythm, okay? Or then you can have a, let's say, middle junctional rhythm. And that's what I was talking about. It means that it's somewhere, the pacemaker, the pathological one, is somewhere over here. That's the one which discharges both atriums and ventricles. But it's just in the middle of the way, theoretically. And that means you will see only QRS complexes. And P. And QRS, and not P. This is T. And you're seeing just QRS complexes, okay? Because P is hidden somewhere over here behind it, okay? So remember, these are junctional rhythms, and I won't talk more about them. Just remember junctional rhythm. Or also you can use a synonym. It's a nodal rhythm, okay? And by the way, this junctional rhythm, it has another synonym, but there is a big group of supraventricular rhythms. And supraventricular means pathological pacemaker could be anywhere except the SA node. So it's supra, or above the ventricles. So supraventricular rhythm. This one belongs there under that. Under all there, it's a general, like the most general term is a supraventricular rhythm. So if the pacemaker is anywhere in the atriums except the SA node, you call it a supraventricular rhythm. If it's from the SA node, you call it a sinus rhythm. Okay? Yeah? Good. And then you can have idioventricular rhythms. That means that the pacemaker is somewhere in the ventricles. Okay, so third one, idioventricular rhythm. So idioventricular means it's originated in the ventricles. And typically, let's say if we talked about that there's going to be a AV block or whatever, or SA node and AV node, they're dead for some reason. I don't know for what. But that the cells somewhere in the atriums take over. Those are the fastest ones. They are the fastest, but they're pretty slow. So typically, if it's a classical idioventricular, you will see just a bizarre QRS complex. And I should elongate that. Because of course they're going to have bradycardia. Okay? Because again, remember, I will repeat it all the time. the pulse is created by the ventricles only. So you will, if you touch him and measure his pulse, he's going to have like 50 or 40. Okay? Yeah? So that's idioventricular rhythm. So pacemakers in the ventricles. And now I'm going to jump to the two most important arrhythmias you should really remember, atrial arrhythmias, because, and the one which is the second most common arrhythmia, or rhythm, I'm sorry, not rhythm. The second most common rhythm you will find is Afib, atrial fibrillation. And you know which rhythm is the most common one? It's the sinus rhythm, is the normal physiological rhythm. And the second most common is pathology, and that's Afib. Okay? And Afib is dangerous by what? Because it's the atriums are not contracting at all. So you all will remember, if it's a chronic Afib, which is most of them, and they're very hard to convert back to normal rhythms. So basically you can convert them, but very soon the patient will have an Afib again, and they're chronic. So you're afraid of a thrombus formation. So remember anticoagulation. So warfarin, they all are on warfarin, okay? All. So Afib. And atrial fibrillation, what is the hallmark? Tell me. Can someone tell me the hallmark of Afib?
There's no rhythm, or there's no specific frequency that there's no synchronization between the atria and the ventricles when they are contracting.
Well, we cannot talk about synchronization because the atriums are not contracting. They're just like moving, like really, like only fibers are moving. They're not contracting at all. There's no synchronous contraction of the atriums, but the hallmark, and maybe you wanted to say this, the hallmark is that it's totally irregular rhythm. Totally irregular in a way. What does it mean? That if you take someone's pulse, you'll see how irregular it is. And the funny thing is the final frequency per minute is like 70 or 80. It's thanks to the protection of the AV node, okay? Because the AV node will just let some of the will just let into the ventricles only at this frequency the pulses, okay? But the hallmark, remember, it's not the F wave, the fibrillation waves. You won't see a P there, but you can see like this. But the hallmark is you see how beat after beat that it's irregular. This is the hallmark of Afib. So you can basically diagnose this from far away. If you just see an ECG from 5 meters, you can say it's Afib. There's going to be a nice QRS complex, typically. And if there are no blocks and other things, but if everything else is healthy in the heart and he's having only Afib, QRS is going to be nice, lean, like this, narrow. And the distance is the RR distance is going to be like change beat after beat. That's the hallmark, okay? And basically, the frequency of the fibrillation of the atriums, watch out, that could be 300 or 450. Atriums can have this frequency, but ventricles, that's the pulse, they're going to have like 70 or 80, okay? So that's why you can live 20, 30 years with Afib, and if you won't get a thrombus, it's okay. Of course, you won't play a football or whatever. I mean, it's hard to do sports with Afib, but you're gonna live, okay? And good thing is that it's not so dangerous in a way that it would somehow the Afib would turn into VFib, okay? So, but you're getting also drugs like digitalis or digoxin, which protects the ventricles, but we don't have time to talk about that. But anyways, the maybe more important thing is you should remember from today, they are typically over here, this is the left atrium, and over here you get those are the veins which are coming from the lungs. And typically how Afib is created, now we found out that the impulse re-entry phenomenon circulates around one of the vessels, and this is what triggers the Afib. So typically what they do, they use a radio-ablation, and they do a scar around from inside around they found the place where it is, and they make a scar around the veins. They sometimes make it from outside as well, so they burn it around, and scar is not conducting, so they keep the fibrillation inside over there, and then the SA node can take over, and they convert them like this. Okay, so with radio-ablation you deal with radio-ablation, people should people who are well trained should do it, but then they can really save the person, and he doesn't have to have Afib anymore if they close it over here in the scar. Okay, yeah. But this is just a comment on the side. So remember, radio-ablation, catheterization, and burning with the radio-ablation. That's the way how to deal with Afib. Anyways, you should know how it looks like on ECG, and that's this way. You look on the distances of the R and R, and they should be wild like this. Totally irregular. Another beat you should know, I'm going to stress from the beginning, is the flutter, atrial flutter. Okay, and flutter looks like this, like shark teeth or of a saw. Okay, and then there is a QRS again. And in contrast, this frequency is not so fast of the atriums as in atrial fib. So this is atrial flutter, and there is some contraction, but also in this case, warfarin, you are afraid of thrombus formation, so you give them. And in contrast with Afib, this is very regular actually. The beat, if you check the pulse, it's very regular. Okay, so Afib is irregular, a flutter is regular. Okay, so a nice example of regular beat, heartbeat. But remember, with flutter, sometimes what can happen, because this is like 3-to-1, okay, 3-to-1, and this is very periodic hitting of the AV node, like it hits the AV node all the time with a frequency of 300, let's say, and sometimes what happens is a D-block, so the AV node will give up, and then you're having this is a ventricle flutter, and that's very dangerous because you're losing the cardiac output, and you're getting into coma. Okay, or you're having syncope, and you deal with that the same way as with ventricular fibrillation. Okay, some cardiologists now say that ventricular flutter is not existing. The older books talk about it, ventricular flutter. Now they think it's more like fibrillation, depends. But remember, with atrial flutter, there's a risk of deblocking and turning it into ventricular flutter. Although nowadays the terminology is very much debated if it exists or not. So just a comment, remember, ventricular flutter is a very elusive, or let's say debated term if it exists or not. Okay. In contrast to this, atrial flutter is a typical, very common thing. It's not as common as Afib, but in terms of comparison, it's much more common than the junctional rhythms, for example. Okay, yeah. So we talked about sinus rhythm, junctional rhythm, idioventricular rhythm, and I showed you Afib and A flutter. Still, common on Afib, the thing how I'm imagining it, why it is totally irregular, is that the discharge runs over here like hell, and really occasionally hits the AV node. And if the AV node is already prepared for another discharge, it's going to send it to the ventricles, and you'll see a QRS complex. And because this is totally chaotic, sometimes it hits it when it's ready or not, and that's why the beat is so irregular, but still for a minute it takes 80 or 90. Okay, yeah, good. So that was rhythm, and we're getting to, in Europe we call it action, but the better term I guess is heartbeat. And the only thing about heartbeat is if it's regular or irregular. And you already know examples. So the other term, heartbeat, and what we care is if it's irregular or regular. And irregular. And you know the examples I told you already. So this is a normal sinus rhythm. Sinus, whatever, tachycardia, bradycardia, you don't care. So rhythm. And or you can put, for example, atrial flutter. That's very regular. In contrast, the best example is atrial fibrillation. Okay? Yep. So this one is the best and the most important bullet for you to mention irregular heartbeat. Okay? Good. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.